Well, good afternoon, and welcome to Ask the Docs, a Fertility Institute of Hawaii live stream. This month is Men's Health Awareness Month, and our topic is infertility awareness. Men's health matters. Thank you for joining us today. We have a lot of great information to share with you. My name is Dr. John Fratarelli. I am here with Dr. Anat Carmone, and Dr. Emily Goulet will be joining us here in a few minutes.
Okay,
November is I think commonly right now known as Movember or No Shave November, but officially it's about just raising awareness on men's health, and so that's why we chose this topic this month. And particularly, for men's health, a lot of it deals around prostate and testicular cancer, mental health, but we're going to try to focus more on obviously fertility because that's what we do, but certainly any prostate testicular issues that someone has does affect their male fertility. Here's Dr. Goulet. Welcome, Dr. Goulet.
Hello.
So I was just giving the intro, and we were getting ready to get started. I guess the first question would be is how common is male fertility issues or male infertility?
Male fertility is very, very common. It's at least 1 in 3 of cases. And, it's even when there's a significant female factor present, it's certainly worthwhile to check the male partner as well, because many times there's also a male factor present, which is, when the male and female factor together are combined, creates a much larger infertility issue. And that's often why the couple ends up in our office.
And I think one obvious thing is that a lot of times people don't know, right? It's for females, a lot of times it's easy to know that there's a fertility issue. They'll have irregular menstrual cycles. They'll know they're not ovulating. They'll know they've had ultrasounds. They'll know there's an issue for whatever reason. For men, I think what's commonly happens is if they're ejaculating and they're not having any issues with erections, they assume everything's fine. But the reality is the ejaculation is not necessarily sperm. There's a lot of other things, and most of the ejaculation is just fluid from other organs, not sperm. And so you don't really know until you do the semen analysis and do the testing for men, and oftentimes that there is a male factor that you said, like you said, somewhere between a third and a half of the cases we will see the male as a component. What are some of the causes for male infertility, Dr. Goulet?
There's a lot of different things that can contribute to suboptimal fertility in a male. I think one of the most common things that I see nowadays is probably exogenous testosterone use. We all hear the radio ads for low T, come get checked out if you're not feeling as energetic or if your sex drive isn't as up to par as it used to be when you were in college. So a lot of men have started testosterone therapy, which may very well be appropriate.
So sex drive in college, that's the norm. That's what we're shooting for. Is that it?
Well, that's what the radio ads seem to suggest. And teenagers and young adult men do have raging hormones, and so their sex drive is probably more than that of what would be considered normal for an adult male, but that might be the goal for some individuals. And so they go back on testosterone therapy, but may not be aware of the severity of the impact that testosterone can have on male fertility. And sometimes that impact may not just be temporary like it is for women. When we go on hormones, we stop birth control pills, our fertility starts right back up where we left off. For men, some of that testosterone therapy can cause permanent damage where the sperm making capability may not come back up to baseline where it was prior to initiating testosterone. So I think that's one of the biggest things that I ask all of my partners, have you ever been on testosterone therapy? Not just right now. Is this an ever sort of thing? And that also goes for anabolic steroids, especially here in Hawaii, Waikiki Beach, like Miami Beach. I also see, I think, an increased number of men on anabolic steroids for bodybuilding, and that as well can impact the sperm making capability.
So just to kind of explain that a little bit, because I think that there's a lot of confusion out there as people think, well, testosterone is kind of good for you and good for sperm. And people also have an understanding, the correct understanding, that when your testosterone level is low, then oftentimes there are issues with sperm production as well. And so people think that maybe just adding some testosterone can help improve that. But it's actually the opposite. It's sort of what happens when the brain senses a high testosterone level. It kind of shuts down the signaling to the testicles to produce sperm as well as testosterone. So you're getting the exogenous testosterone when you're taking it. So your testosterone level is high, but your brain also has shut down that signaling to produce sperm as well. And so we can see issues with the sperm, like just a low count when people take testosterone, or if they've been on it long enough at high enough doses, we'll see no sperm. The treatment for that is first and foremost to stop the testosterone, and we can then see if the sperm production returns. We'd expect to see some return within 3 months because the sperm cycle is about 3 months long. Another option is to give some medication which kind of prompts the brain to start that signaling process again. So medications that women will often take, things like Clomid, which will stimulate the brain to kind of make additional FSH, which will then signal the testicles to produce additional sperm. That doesn't always work, but again, it's one way to kind of potentially reverse the effects. Or there's also the option to give injectable medications such as HCG, for example, which is pregnancy hormone. We can give that to men if they take a pregnancy test. I guess they'd show up pregnant. And that pregnancy hormone in and of itself can also stimulate the testicles potentially to produce sperm. Again, it's not... If the testicles don't have sperm producing capability for other reasons, that's not going to work. But if it's a hormonal issue and the testicles have been suppressed by an issue like taking testosterone, then those types of treatments may help.
I guess what I would add maybe to as well is that there can be some organic causes where there can be something wrong with the testicle itself, kind of a blockage potentially that can be caused by a history of an infection, a prostate infection, an epididymal infection. Some men will know that they actually have a varicocele, an enlarged testicle, and basically that's just the veins in the testicle being large. And sometimes they'll know that, and the varicoceles, depending on the size and severity, can create some symptoms. But the reality is that what we find is about 25% of men actually have a varicocele if you look, and without having any fertility issues whatsoever. But that is something that it can cause fertility issues. And so if somebody's having testicular pain or any kind of testicular issues, then we always send them to the urologist for that evaluation. And like Dr. Carmel was saying, sperm production is really all related to hormones, right? It's hormonal. I always tell patients that, men and women, we're kind of hardwired the same way. FSH, LH, are coming from the hypothalamus. And if you're a female, if you have ovaries, it causes follicles to grow and you to ovulate. If you have a testicle, then it causes spermatogenesis and you get sperm formation, but you still have to get that happening. And so there are medications that we use for both that are working the same way. There also can be genetic issues. If someone has a history of cystic fibrosis or has cystic fibrosis carrier, for instance, they can actually have a blockage as well, and that's something that we can assess with evaluation, either semen analysis and exam. Anything else that we've missed as far as causes? I guess the other one would be, anybody that comes in with significant medical problems, right? So somebody with significant diabetes or heart disease, they may be on medications that are causing issues for them. So that's, so obviously the first thing we do in medicine, no matter who you are, no matter what you're doing, we always get a history and physical on you, right? We always kind of figure out what medical problems do you have, and what medications are you on, because those can contribute to whatever you're coming in for that day.
Yeah, I think you've mentioned everything. The other thing I don't know if you mentioned was cancer. There are certain cancers that can essentially damage the cells that create sperm, and cause blockages as well. So it is important whenever somebody has a significant male factor. We usually will refer them to urologist, just for a urologic exam to ensure that there is no condition that could be more serious that's causing that. Genetic issues, you mentioned cystic fibrosis. There are also some genetic issues which cause cystic fibrosis. Being a cystic fibrosis carrier causes kind of an obstruction, but there are other issues which cause problems with sperm production altogether. So problems with karyotype, some men with certain types of translocations, or an issue with their karyotype, with the number of chromosomes that they have, may potentially have issues with sperm production, as well as something called the Y chromosome microdeletion, which is more don't ask me how common, but it's actually seems to be a relatively common issue, where kind of a portion of the Y chromosome is affected. The male is completely normal, other than sperm production, which is either extremely low or completely absent.
And just to build off of that cancer thing, having had treatment for cancer too, most of those treatments, whether they be radiation or chemotherapy, are also gonatotoxic. So,
yeah. In terms of other factors that affect male fertility, there's certainly plenty of environmental factors, I think, that people need to be aware of, and those can present differently. So sometimes the issues can be subtle. Sometimes we just see issues with the shape of the sperm. There are a lot of studies of kind of linking certain environmental factors to issues with semen quality, sometimes with live birth, but a lot of it is, kind of larger epidemiologic studies, and it's difficult to really understand, okay, yes, if you stop doing this or stop this exposure, does that mean you're much more likely to have a baby? Those are kind of the tough questions to answer. But I think the big ones that we do know about are going to be cigarette smoking. That's pretty well understood that, quitting smoking hopefully does improve sperm function. Alcohol abuse. Needs to be a lot of alcohol. I'm not condoning drinking, but moderate drinking typically does not influence sperm production. It needs to be pretty heavy drinking. Drug use, obviously, obesity in men, a lot of that too is hormonal, because the kind of estrogen testosterone ratios are thrown off balance. And then, there are other issues which can affect sperm kind of once it's already out of the body. Okay, so for example, out of the male's body. So for example, certain lubricants are spermaticidal. And, so I do tell patients that if they're going to be using lubricants, that they should utilize lubricants that are specifically tested and safe for sperm. So there's some commercial ones available that you can buy, over the counter. Pre-Seed is kind of one of them that I know about, but there are certainly other ones as well, which are safe because they're tested for sperm. And also things like, canola oil actually is not spermaticidal. Don't just go grab any natural oil or anything. Don't use other stuff, but canola oil is okay.
Yeah, and that is important. So the canola oil we know is fine, but not all oils are good. So this all sounds kind kind of scary. I mean, we you know, there are a lot of things that can cause fertility issues for men. What are some of the treatments for these things then? I mean, so like for instance, it's easy to say for environmental factors, okay, stop smoking, drink less, don't do drugs. If it's, lose, and I don't know if you mentioned this yet, but obesity, there is, certainly a significant effect of obesity on sperm count and semen analysis as well.
I did mention obesity.
Okay. All right. Just well, it doesn't hurt to say it.
Pay attention.
But like, and then you did kind of mention treatment for anyone who's been taking testosterone,
Right.
what we would potentially do for them. But what about some of the other things? What if, so if someone is just has a very low count, a very low number of sperm, and it's not moving real well, are there other options that they have?
I make the comparison to my patients that the human egg is a little bit like a chicken egg. It's got a shell on the outside called the zona pellucida, and it takes a whole team of sperm chipping away on the outside to make a crack big enough for one sperm to swim in. So for that reason, sperm numbers count. And if sperm numbers are extremely low, we call that oligospermia. We're not able to, the sperm may not be able to actually penetrate and fertilize the egg. There are technologies now where we can help assist that and make that happen. It's called ICSI, intracytoplasmic sperm injection, but that does require the woman to go through IVF to have an egg retrieval so that we have eggs in a petri dish that we can then look for the best sperm in the sample and inject that single best sperm directly into the egg. And so we can obtain that sperm in different ways. Sometimes we can retrieve it from an ejaculate if the man is able to produce an ejaculate. If the numbers are so low where the ejaculate doesn't really have enough sperm for that, we can coordinate with a urologist so that our urologist can retrieve the sperm surgically so that we can have sperm to work with for the ICSI and IVF fertilization procedure.
There's also the option potentially to do intrauterine insemination, depending on what the counts are. If the counts are very low, then going straight to IVF with ICSI is necessary. But with a more mild sperm factor, then trying intrauterine insemination helps. What we do with intrauterine insemination is we concentrate the sperm into a tiny droplet and put it into the uterus, and that's just increasing the number of sperm that are able to get to where they need to go. Most sperm in just intercourse is lost in the vagina, and so simply by concentrating it and putting it into the uterus, the turkey baster method, if you will, we're increasing the chance that a good one makes it to where it needs to be. So that's certainly another option.
And we're talking about the sperm a lot, and I guess we kind of skipped over like testing, like semen analysis a little bit. We talked about it a little bit, but I think it is important to. I mentioned earlier that most of the ejaculate. Sorry, there's an ambulance outside. Most of the ejaculate is really just fluid, and it's not the sperm. And so when we do get the ejaculate, and we give when men do a semen analysis, they're given instructions on how to produce a sample, and typically that we need them to abstain, no ejaculate for at least 2 days. Most people will say you should have at least have had an ejaculate at least 7 days prior, but I typically tell patients somewhere between 2 and 5 days is really the best time, and that's going to give us the best sample. And obviously, when they're giving a sample, they don't want to use lubricants. No intercourse, no sexual activity at all. And if they have trouble ejaculating without help, then we do have special condoms that they can use that will not kill the sperm. And we also have special collection cups that they can use that won't kill the sperm. We have had people bring sperm in, Dixie cups and other things, and the sperm is you don't get a good accurate semen analysis at that point, because a lot of sperm is just going to die because it's whatever it's in is toxic. But when we do look at the sperm, basically the first thing we look at is that what's the volume of the sperm? How much volume is there in the ejaculate? And so there's a minimum amount and a maximum amount that we should have. It should have at least about 1 centimeter to 1.5 centimeters of volume. We look at the pH. We look at then we put the sperm in this we call a macler, and basically we're just getting a drop of the sample after it's liquefied for about 30 minutes. We get a drop. We put it on the slide, and it has a little grid on it. And by looking at this grid under the microscope, you can count the number of sperm that are in 10 little squares, and by doing that gives you a concentration per million. So if you see 10 that are moving, that's 10 million per milliliter. So it kind of gives you the value for it. And so when people kind of wonder, how are we counting 80 million sperm? We're not. We're counting 8 sperm or 80 sperm within 10 squares, and then that calculates out to 80 million. So we count the number of moving sperm, and then we count the number of sperm that aren't moving within the same 10 squares, and that gives us the total number of sperm, and we can get the percent that are moving that way. We also look at how they're moving. We look at, are they moving in circles? Are they moving fast or slow? And are they progressing in a linear fashion? Because that all does have a factor on fertility. And there's several other things that we look at, but one of the other main things is we do a staining for morphology. So the shape of the sperm, we're looking to see, is the head shaped appropriately? Is it the head to the tail size appropriate? Does it have 2 tails, 2 heads, or any other abnormalities? Because those abnormalities can affect fertility as well. But the semen analysis is by far the first thing that we're going to do for men when they come in with any kind of fertility issue, or just the evaluation of fertility. And then based on what we see with the semen analysis, then we kind of go about either getting other testing for them, or sending them to a urologist, or other potential treatment. And as Dr. Carmon said, the amount of sperm and the amount of sperm that's moving would then determine, can you do IUIs, or do you potentially need IVF? And as Dr. Goulet said, ICSI, intracytoplasmic sperm injection, putting one sperm directly into the egg, has revolutionized what we can do for male fertility. Before the 1990s, if a man had very little sperm, they had to use donor sperm. Now, if a man has 12 sperm, we just need 12 eggs. And so typically for men, if we see sperm, we're usually seeing in the thousands, hundreds of thousands, even millions of sperm for men. So there's usually if we see sperm, there's almost always enough for us to do IVF with ICSI procedure.
And I wanted to sort of circle back around to one of the causes of oligospermia. Sometimes can be varicoceles, in which a urologist may have already diagnosed. And there's some data out there to suggest if the varicocele is very large, that it might be amenable to treatment surgically from the urologist, either resection or coiled embolization. But if the varicocele is not quite so large, but the semen analysis is suboptimal, the amount of improvement that we would see from trying to treat the varicocele may not yield drastic improvement in the semen analysis. And those individuals would still probably need either inseminations or IVF with ICSI regardless. And so I see a number of male patients that have been referred to me. They're like, I'm not really excited about having surgery on my testicles. Can we avoid this? And, that's a conversation to have as far as whether or not the semen analysis can be optimized by that surgery, or if perhaps just going straight to fertility treatments with IUI and IVF would be preferable.
Yeah, I think it's really important to note that unlike most medical diseases, the treatment for male factor infertility often involves the female partner's body. And so that's the hard thing. And also for the female partners too, because many times they think like, you have a problem, you need to go to the fertility doctor. I'm, going to just wait to see what happens with you. Well, okay. But the majority of the treatments and the most effective treatments are things like intrauterine insemination, IVF, and ICSI, which do, for better or for worse, involve the female partner in a major way.
Right.
Yeah. So I do definitely urge both partners to kind of come in together. And of course, we all know that the opposite is true as well, where female partners will come in and say, that they're going to do their whole workup and treatment first prior to the male partner. But, I tell them the same thing, like at least 1/3 of couples have a significant male factor. So even if we find an issue with you, it makes sense to go ahead and just get that semen analysis to make sure we're still doing the right treatment for you. I think one of the things we didn't talk about much is patients who have a history of vasectomy, and if there are any options for those patients. So I think that it does depend a little bit on how far out the male partner is from vasectomy, because of the potential success for vasectomy reversal. So there's two options with vasectomy. There's either vasectomy reversal or in vitro fertilization utilizing aspirated sperm, right? And so if the partner is less than 5 years out from vasectomy, then I think both of those options are typically discussed and offered. But if the male partner has been is kind of remote from vasectomy, then typically the vasectomy reversal is a lot less successful. And then in vitro fertilization is much more strongly recommended. The other thing too is that you have to keep in mind the female partner in that as well. So doing a vasectomy reversal takes some time. And if the female partner is 42 or 43, then she may not have that much time to kind of wait, sort of a watch and wait type of scenario to see if the obstruction resolves. So that's another thing to keep in mind. But the good news is that if vasectomy really is the only issue, then the success rates with in vitro fertilization are, relatively good, obviously depending on female partner age. And in fact, IVF for a true male factor, unless it's a very, very severe male factor, but IVF for male factor is one of the kind of most successful types of IVF. It carries a better prognosis than IVF for severely diminished ovarian reserve, for example.
I get a lot of questions from my patients regarding some urban legends or some things they've read on the internet that might help improve their semen analysis. And I was wondering if you guys had any comments regarding spending time in the hot tub or wearing whitey tighty briefs, or maybe some preconception vitamins for men.
I think that certainly the testicles are outside of the body for a reason, right? So because they're supposed to be cool. The sperms and the testicles are supposed to be cooler than body temperature. So going in hot tubs typically doesn't have much of an effect unless somebody's spending a lot of time on in hot tubs. The other thing that sometimes will have an effect is someone who's on the bike, an Olympic type cyclist. Someone's on the bike a lot. Then that's really just testicular trauma more than anything. But I think going in hot tubs for a short period of time is very minimal effect, if any effect. And then the tighty whities probably have little to no effect at all for men. I think but the problem is when there's an issue or a potential issue, you want to try to get rid of everything possible that could be a problem, because you don't know that for that one person that may not be the issue for them. And when you look at studies and statistically, yeah, the chance of it being an effect is very minimal. But you don't know for that one person it isn't having an effect. So I think when we're seeing that one person, we try to tell them, okay, well, everything that they should do: don't smoke, don't drink, or limit the alcohol, be as healthy as possible. The vitamins are probably plus or minus that, again, minimal to no effect for most men. But and there's the Moxie study that was out half a year ago. Do you guys remember the timing for that? That basically showed that the antioxidants have in these supplements have very little to no effect, which we kind of already knew probably. But again, it kind of goes to the fact the matter of there are some patients that they may benefit. You can't tell a patient that it may not benefit them, so or may not be a negative for them. So you want to make sure that you're doing everything possible in order to optimize the treatment for that patient.
Some of the antioxidants have been shown to improve sperm quality, but that hasn't translated to improving fertility and live birth rates in their female partners. So I usually explain, it's sort of like, well, what's the point of improving your sperm if it's not going to help you have a baby? I mean, it's just
like the varicocele, right? The varicoceles, when you look at it after a procedure, you see improvement in a semen analysis, but you don't see improvement in outcome or if they needed an IUI before the varicocele repair, they still need an IUI afterwards, and pregnancy rates are exactly the same. So,
one more thing that I wanted to say, I think we probably do need to finish up soon, but sperm quality and male factor infertility is more than just what you can see on the semen analysis. And that we understand now because we see a lot of studies linking certain things to live birth, but not necessarily to semen quality. And similarly, we see things that are linked to semen quality, but not necessarily to live birth. So there's more to just sperm. And of course, there are tons and tons of molecular things going on. There's all kinds of stuff that we don't really even understand and know about, and so much to those little swimming sperm that we don't see on a semen analysis. And so now there are some tests in development and some tests that are clinically available that are trying to kind of delve deeper into sperm function. One of them is the SCSA, which looks at sperm DNA fragmentation. I think SCSA might be the company, but anyway, there's probably a few different ones that look at actual sperm DNA fragmentation, and that has been associated with recurrent pregnancy loss mainly. So, that's another aspect of sperm quality that we could test that's not really available on kind of a routine semen analysis. And then similarly, there are now treatments which are kind of aimed at choosing the best sperm and improving sperm quality. One of them, is utilized along with IVF, and that's called the Zymo. That's kind of a little maze that we put the sperm through, and the winners may be just a better quality, and those are the sperm that we choose to then fertilize the eggs. And that may show some improvement actually in recurrent pregnancy loss or reducing rates of miscarriage as well, and hopefully improving overall outcomes. So that's kind of a relatively new device. So it is an exciting field. I think there's a lot of stuff out there that we don't completely understand and is not really clinically utilized at this point.
Yeah, certainly. And I think, I would just kind of end, or last thing I'd like to just mention is that, again, kind of going back to the semen analysis, the semen analysis was designed to tell us what are the chances, or is the sperm normal and abnormal, but ultimately, is the sperm adequate for reproduction with intercourse? It really doesn't tell us a lot else. So it's the semen, and that's what a lot of times men will really focus on. Is it it's the morphology is abnormal, or the concentration is abnormal, and really what that tells us is that depending on what the level is, your ability to get pregnant with intercourse may be a little bit lower or drastically lower, depending on what the finding is. But the reality is, depending on how much sperm is there and the other findings, there's typically always going to be other treatments, but there's only so many ways to get pregnant, right? You got the egg, you got the sperm, so you have intercourse, you do an intrauterine insemination where you put sperm into the uterus to improve the number of moving sperm that are there. You do IVF, in vitro fertilization, with ICSI, intracytoplasmic sperm injection, and then obviously, like I think Dr. Goulet said earlier, if there's a testicular blockage, you can do a testicular biopsy to get sperm, but then you still have to do IVF and ICSI. So there's still only a couple of ways to do it. But with men, as long as there's sperm, their fertility outcome is typically going to be fairly good. And then it does come down to the female partner and the egg. The egg just is so much more determinant of the final outcome than the sperm. And I think that the men initially, like you said earlier, Dr. Carmon, men sometimes are hesitant to do a semen analysis up front because I think they're worried about what it's going to show, and is that going to mean they can have a child, but the reality is, as long as they have sperm, we can almost always do something to help them.
And even if you don't have sperm, many times we can get sperm from the testicles. So don't be scared. So, all right.
Any closing comments, Dr. Goulet, Dr. Carmon?
Oh, yes. One really quick one, because maybe some people are wondering how, maybe if they haven't been to a fertility center before, how do we get a semen analysis? What do you actually have to do? So you have to produce a sample into a cup. You can either do that at home and bring it in within half an hour or so. You need an appointment, though. Please don't show up at our clinic with a cup of semen with no appointment. But if you have an appointment, then it's perfectly acceptable. And the other way to do it would be to use our collection room and produce a sample in a cup. And then we take that from you and we give you those results a few days later. So it's nothing to be ashamed of. We do it every day. Every single one of our patients who needs a sperm source, that sperm source is doing it. So yeah, please do give us a call to schedule a consultation if you have any other questions about it.
And along that line too, you have to be a patient, because it's a laboratory test. You have to be a patient of ours in order for us to order it for you. You can't just call and say, I want a semen analysis, and come in and get it done. Some provider has to order it for you, either whether it's your primary care doctor, urologist, or a fertility doc. Someone has to order it for you so that they can ultimately be responsible for that lab test. Just like you can't go into any lab and get blood drawn without having an order.
Right. All right. Well, thank you everyone for listening. I hope you guys find this informative. And you guys can comment after this is over, and we can try and answer those. And otherwise, we look forward to meeting you guys in person.
Yes.
All right.
Happy Movember.
Thank you.
Bye, everybody.